All right, guys, we're going to talk medical scenarios real quick. Okay, make sure and review your uh, procedural guidelines. It's going to have a lot of good information for you. But we'll talk. We're going to start with the scene survey, and then getting into our general impression, our primary assessment, down into our secondary assessment. So scene survey for every scenario is always going to be something that is either referred to as scene size up, scene survey, pre-arrival questions. Always going to start with our appropriate PPE, which at minimum is going to be gloves. Different calls may require a gown, face mask, eye protection, or gloves and eye protection, gloves and face mask, whatever. But at minimum, you're going to want gloves on every single scene. As soon as we get our dispatch information, we want to start asking ourselves scene safety questions. Okay, what time of day is this? What part of town are we going to? What is the call, right? If it's a altercation at 2 a.m. on a Saturday morning in downtown Albuquerque, probably not safe for me to just walk into it. I'm going to want PD on there so that I can have some crowd control going on, so I don't get anybody else trying to get in there. And that scene safety is not just an initial question, but again, it's going to be a dynamic beast that is constantly changing and things that we need to reevaluate, because a scene that's safe initially can turn unsafe real quick. So that scene safety, along with thinking about it as soon as we get dispatched, whenever we arrive on scene, before we get out of the truck, we're going to decide again if it's safe or not. If we got called at 3 o'clock in the morning to a very bad part of town, and you pull up to the house and there's not a single light on in the house, there's not a single light on outside, right? A little bit unsafe to me, so I'm going to call PD, have them come and check out that scene for me. One thing about mechanism of injury, nature of illness, this is going to start to get us into the mindset for a few different things of what we could be walking into as far as the injury itself, the disease process itself. It's also going to play into additional resources, right? If we had a rollover car accident that the patient's car flipped several times, okay, definitely going to want fire department to start heading that way for traffic control, but also may need extrication, right? So additional resources from that standpoint. It's also going to make us start thinking about different things that we're going to want to take in with us, right? Respiratory call, okay, cool, I want my oxygen tank, possibly my respiratory meds, my oxygen delivery devices. I don't want to get on scene, walk in and go, oh, you weren't lying, you really can't breathe, let me go back to the truck and get my oxygen tank. Want to think about number of patients from the standpoint, again, additional resources. What am I able to handle? If it's me and my partner on a truck and we get on scene and there's 6 patients, I can't take care of 6 people at the exact same time. And if they're all the same acuity, then I really can't bounce between all of them. So I'm going to need additional resources to come in and help me out. Additional resources can be anything. PD, so the police department, sheriffs, fire department, more ambulances, ALS units, ILS units, helicopters, animal control, P&M, gas company. Anything that you can think of can be an additional resource. Even if it's a medical, we're always going to take into account that we might possibly have to do C-spine, because medical emergencies do lead to trauma falls, to where somebody could have a neck injury. Diabetic emergency could lead to a car accident. So again, we need to think about possibility of needing to take C-spine precautions. That's our scene size up, our scene survey. Again, these are things that are going to keep changing as we get on scene. So whenever we arrive on scene, we want to look at how our patient is sitting. Are they standing? Are they walking around? Are they saying that they're having trouble breathing, but they're up walking around smoking cigarettes? Or are they saying that they're having trouble breathing and they're trying hard and can't breathe, right? Different things are going to play into that. So how do they look? Are they tracking us? Are they awake? Are they laying in a pool of blood? Are they surrounded by empty alcohol bottles, drug containers, medication bottles? a bunch of needles and syringes laying around? Are there a bunch of oxygen tanks and oxygen tubing laying all over the ground? We want to take all that so that we can start to kind of form this picture of differential diagnoses of what could be going on, so we know which way we really need to start trying to assess them. As we approach our patient, we're going to look, and if they're awake, then we know that they're A on AVPU. If they're not really paying attention to us, it's, hey sir, how you doing? How you doing? If he responds to me at that point, then he's V on AVPU because he responded to verbal stimuli. If he doesn't respond, we have to come up and give him a nice sternal rub, and he responds at that point, whether he wakes up and goes, hey, what's going on? Or he moans, then he's P on AVPU because he responded to painful stimuli. If we don't get any response at all, then he's U and he's unresponsive. At this point, we do need to address any life threats, so we need to look for any gross hemorrhage, any obvious life threats to us. So again, gross hemorrhage, are they bleeding all over the place? Do they have an amputation? From where I'm standing, do I not see any breathing? Anything like that. If they are unresponsive on AVPU, we do want to do CAB instead of ABC, so we want to do circulation, airway, and breathing instead of airway, breathing, circulation. Reason for that is if they don't have a pulse, no matter how much oxygen I give them or how well I maintain that airway, it's not going to do them any good if that blood's not circulating, right? Our red blood cells carry our oxygen. If I'm losing those red blood cells, or if they're not circulating, then the oxygen's not attaching to anything and it's not perfusing the vital organs, the brain, the heart, right? So to assess somebody's airway if they're awake, I'm going to say, hey, how's it going? You know, if they talk back to me, I know that they do have a patent airway. I will go ahead and look at their airway, make sure that there's no blood, vomit, excessive secretions going on, anything that I may have to go ahead and apply suction for. I do want to make sure that he is breathing adequately. So I want to assess, is he breathing fast, slow, deep, shallow? Is it regular respirations? Is it irregular respirations? Okay. I'm not super concerned about saying, oh, he's breathing 14 times a minute at this point, right? I'm not super concerned about that point, the number, because if he's breathing slow, I need to address it. If he's breathing fast, I need to address it. The specific number is not going to really be super important right now in our primary. It's a rapid assessment of their vitals. So airway, breathing, and circulation, right? If he needs oxygen at this point, I'd go ahead and put him on whatever my appropriate oxygen device is, so nasal cannula, a non-rebreather. If he's not breathing, then I would do a BVM. If he is unconscious, the way that I'm going to check his airway, we'll do a head tilt chin lift. I'm going to go ahead and open up his mouth, and I'm going to assess his airway by physically opening it up and looking in it. We talked about his respiration status, circulation. Again, we want to go ahead and check a radial pulse. I want to know, is it fast, is it slow, is it irregular, is it regular, is it strong, is it weak? I want to make sure that I don't see any external bleeding that needs to be controlled, as well as I want to look at their overall skin condition. Are they pink, warm, and dry? Are they pale, cool, and diaphoretic? Diaphoretic means sweaty. Are they clammy? We want to assess their skin color, temperature, and moisture level. This is going to talk to us about perfusion status along with their pulse. So once we check our ABCs, this is going to tell us, based on ABCs and general impression, are they sick or not sick? By saying sick, we mean that they're emergent and they need to be in the hospital an hour and a half ago. Not sick, they're not emergent. I can kind of stay on scene, ask some more questions, take some more vital signs before I really need to load them up and start transporting. After this, we do want to go ahead and start into asking some history questions. So we'll go through OP, QRS, TU, as well as sample. So sample, we'll ask any allergies by simply just asking, hey, do you have any allergies? Are you allergic to any medications, food, environmental conditions? What medications do you take, or what medications are you supposed to take that you're not currently taking? What past medical history do you have? Diabetes, heart attacks, high blood pressure, have you ever had a stroke before, asthma, anything like that. We'll ask them the last time that they had anything to eat or drink. And then we're going to ask them what was going on that led to them calling 911. Okay, so if it was he's having trouble breathing, well, what were you doing whenever the breathing started, right? Because if he was just sitting on the couch and that difficulty breathing started that way, paints an entirely different picture than if he was going for a run and then he started having difficulty breathing. Okay. For OPQRST, want to know the onset, so when it happened. We want to know anything that makes it better or worse, so provocation or palpitation, P. We want to know quality. What does it feel like? Stabbing, crushing, throbbing, constricting. Have them explain to you the kind of pain or pressure that they're experiencing. Radiation, does it go anywhere else? Right? For example, if we had somebody with chest pain and they're complaining of substernal chest pain, does it radiate anywhere? And if they tell us that it goes up into their neck and left jaw and down their left arm, then that chest pain is radiating from their chest up to their left side of their neck, left jaw, and down their left arm. That's what we mean by radiation. We want to know severity, so on a scale of 1 to 10, 1 being no pain at all, or very little pain, to 10 being the most painful thing they've ever experienced. Want to know how long it's been going on, and then we want to know if this has ever happened to them before, as well as digging into any of those, right? Oh yeah, this happened 5 years ago. Okay, I don't want to just move on after they say that. But, okay, well 5 years ago, what did the hospital say it was? What was going on with it then? What did they do for you? After we've accomplished that, we can go ahead and start taking some vital signs. We'll want to get their pulse, the rate, regularity, and strength. So we go ahead and get a pulse. We check for 15 seconds and then multiply that number by 4. 30 seconds, multiply it by 2, or you can count for the full minute. So let's say that we came back with 88 strong, regular at the radial. Then we'll want to go ahead and get respirations. So we want rate, depth, and effort. So we can go ahead and count those out. Again, either 15 and then multiply by 4, 30 and multiply by 2, or count for the full minute. So we'll go ahead and say that he had a respiratory rate of 14, non-labored at this time. We'll go ahead and listen to lung sounds. So for lung sounds, just like in the progressive airway, we'll do upper versus upper, lower versus lower. Go ahead and listen in the back as well. We do want to go ahead and get a blood pressure on them. So we'd go ahead and place the blood pressure on the upper extremity, listening in the antecubital fossa, the front of the elbow. Get a blood pressure, comes back 132/78. Okay, that's fantastic. If we need to, we'll get a BGL. If we are having medical problems and they need oxygen, then we might as well go ahead and put them on an end-tidal nasal cannula so that we have the end-tidal. Potentially needing to put them on an EKG monitor. At this point, we'll go ahead and assess, do a in-depth, thorough secondary assessment of their chief complaint. Right? So if he's having abdominal pain, right, we're going to, one, we'll assess his abdomen visually. We'll go ahead and assess his abdomen. We'll palpate his abdomen, starting away from the side of the pain and working our way towards it. We'll go ahead and ask all the important questions about abdominal issues. Okay, how long's the pain been going on? Have you eaten anything spicy? Any nausea, vomiting, or diarrhea? Any problems urinating? Any problems having bowel movement? If it's a female, we want to ask pregnancy-related questions. Any chance that you're pregnant? When was your last menstrual cycle? Was it normal? From there, we'll go ahead and say, okay, I think that the problem with my patient is, if we're still talking abdominal pain, let's just say that I think that it's gallstones on this gentleman because he's having right upper quadrant pain with a lot of nausea. The interventions that I went ahead and did for him, put him on oxygen. If let's go ahead and, we requested ALS, so we'll have ALS intercept with us for anti-nausea medications, possibly pain medications, and IV. We will reassess our patient, every 5 to 15 minutes, 5 minutes if they're critical, 10 to 15 minutes if they're non-critical. We're going to reassess the site of the pain, and then we'll go ahead and give a radio report to the hospital. So we'll say that we are taking him to UNM. So UNM, this is CNM Ambulance 1. Come in at you, code 1, no lights or sirens, with a 25-year-old male. Chief complaint today is going to be right upper quadrant abdominal pain with associated nausea. Currently, vitals are as follows, and I'm going to give the vital signs that I took. So blood pressure of 132/78, pulse of 88 strong regular at the radial, satting 96% on 2 liters, respirations 14, non-labored with clear lung sounds. If you guys don't have any questions, we'll be there in about 5. That is your medical scenario. It's the same thing for every medical problem that you have, just the questions that you ask and the part of the body that you're going to assess is going to be different based on that patient's